everyone. Okay, so sorry for the delay. Welcome to the Kursus Asas Biopsi Zone Borneo 2021, jointly organized by Oral Pathology and Oral Medicine Unit of Hospital Umum Sarawak and Oral Pathology and Oral Medicine Department of Hospital Queen Elizabeth Sabah. Okay, to formally start this program, I would like to invite Dr. Ajura Jalil, Ketua Kepakaran Patologi Mulut dan Perubatan Mulut from Unit Histopathology IMR, to deliver her welcome remarks. Let's welcome Dr. Ajura.
Terima kasih Dr. Liu. Assalamualaikum dan selamat pagi semua. Welcome everyone to Kursus Asas Biopsi, Teori, Prosedur Klinikal and Makmal Peringkat Zon Borneo 2021. Untuk pengetahuan semua, this kursus biopsi, before this kita adakan secara fizikal bagi secara zone. And then kita ada ceramah and also hands-on to the participants. And because kita punya pandemic COVID-19, we have to do it virtually this year, fully virtual. So I would like to congratulate Dr. Noshalin and team because untuk bantu perumus untuk menjayakan kursus ini, kerana I think for virtually is actually difficult because Semenanjung, Sabah and Sarawak, I think quite difficult because of the internet access and everything. Okay, and also terima kasih kepada pakar-pakar OPUM, Dr. Sabamika, Dr. Fairuz, Dr. Liu, Dr. Mashira atas kerjasama, and also tanda sekali lagi kepada tim ini kerana dapat menghasilkan video dan juga manual yang akan digunakan semasa kursus ini. Saya berharap kursus 2 hari ini akan dapat memberikan pendedahan kepada peserta-peserta tentang kepakaran OPUM, cara-cara management of OM and OP cases, and also pengambilan biopsi, dan juga harap dapat beri pendedahan juga kepada peserta-peserta tentang behind the scene pengambilan tisu spesimen di makmal histopathology. So sekali lagi congratulations to tim OPUM Hospital Umum Sarawak dan juga Hospital Queen Elizabeth atas kerjasama dan kejayaan mengendalikan kursus hari ini, 2 hari ini, and also to all participants, and enjoy and have a wonderful kursus, and stay safe everyone. Thank you.
Okay, thank you very much, Dr. Ajura, for her welcoming remark. Okay, without further ado, I will begin the program with first ceramah entitled Introduction to Oral Pathology and Oral Medicine, given by Dr. Noshalin. Dr. Noshalin Pauline Haji Kipli is specialist consultant in OPOM from Klinik Pakar Pergigian Hospital Umum Sarawak. Let's welcome Dr. No.
Assalamualaikum. A very good morning, everyone. Alright, I am Dr. Noshalin. I think you've seen and heard me before this. First of all, I would like to say thank you to Dr. Ajura for joining us this morning. And I think before we start, I would like to thank all the hardworking members in this group who has been really, working upside down the past few days trying to get this workshop running. Alright, so but I don't think we have all the participants in yet. But unfortunately, we still have to run the workshop because we're running late. Now, before we start, I would just like to tell you that all the lectures we will give you a soft copy of all the lectures later on. We will make like a PDF booklet, so there's no need for you to ask us for the presentation later on. Yeah. For the videos, we will upload it to the our FB page, okay, so you can view it later on. If there is anything that you would like to ask or there is some problems, you can either raise your hand. There's a button down at the page later on. Yeah, you can raise your hands later on, or you can type into the chat box, okay. Now, for any of your questions, if you have any questions, just put them in the chat box. We will put it up and try to answer at the end of the session. If some of the questions that you can't come up with now and you want to ask us later, you can also email to us at the same email that you received the link, and we will try to answer it tomorrow. Now, all your questions and the answer to all your questions, we will submit it together as a soft copy later on, together with all the lectures. All right? Okay, so enjoy the session. Now, can I have Dr. Mesh to run the presentation, please? Thank you.
Okay, Doctor. Thank you very much, Dr. Noel, for the informative session. So I believe all of you know more by now about what is OPOM, right? So now we'll continue with second ceramah by Dr. Savambika Kazaki-Dasan from OPOM Hospital Umum Sarawak. Okay, Dr. Savang will be discussing on understanding clinical and histological correlation. So now, without further ado, let's welcome Dr. Savang.
Hi, good morning. Hi, good morning. I'm Dr. Sarvambika. I'll be giving the second lecture. Hope it will be beneficial and all of you will enjoy it. Thank you.
A very good morning to all the participants who are present today for our Kursus Asas Biopsi Zone Borneo. Glad that we from East Malaysia are able to gather online for an informative session today. I'm Dr. Sarvambika. I'm an oral pathologist and oral medicine specialist from Hospital Umum Sarawak. Today I will be continuing with the second talk, and my presentation will be on understanding clinical and histological correlation. These are my objectives. At the end of the presentation, I hope I will be able to highlight the importance of providing adequate clinical information for making histological diagnosis. I've put up a few case scenarios which we will be discussing so that we can see how this clinical info are utilized in order to make a diagnosis. Besides, we will also be going through a few basic terms in histology that are commonly used. We will also be looking at some mucosal lesions and comparing them clinically and histologically. Without further ado, let's start. We as clinicians can't escape from making oral diagnosis. In fact, it is part of our profession and has become bread and butter. So in the process of making a clinical diagnosis, we start by taking history and followed by clinical examination. With all the information obtained, we plan for an appropriate investigation that the patient needs. This can be in the form of blood tests or some kind of imaging modalities. The information from the clinical investigation, the clinician will make a clinical diagnosis. However, in some cases, he or she might still feel doubtful with the diagnosis made. So, the clinician may proceed to do a biopsy and send the tissue for a histopathological examination. That's when oral pathology comes in. With the histopathological result, the clinician later will come to a final diagnosis and plans further management for the patient. So what is histopathological examination? Histopathology is defined as diagnosis and study of diseases of tissues. In other words, it refers to examination of the tissue, the biopsy tissue under microscope, and then giving a diagnosis so that the clinician can plan further how to manage the patient. We, the pathologists, in the process of making a histological diagnosis, we combine the clinical findings and the histological features. That means the histological diagnosis must always match the clinical features present in the patient. We always make sure these two components match each other. So why is it important? You may think that isn't that every lesion has got peculiar histological presentation? Then why do we need the clinical information so much? No, you are wrong. There are a few reasons why we always need to correlate with the clinical features. That's because of the pitfalls that are present. So first of all, I would like to remind everyone that not all tissues biopsied have classical textbook presentation. So to further explain this, let's see the picture down here. On your right it is the Classical Okc, a histology of a Classical Okc that have 6 to 8 cell thickness, with a corrugated surface and a flat epithelial ridge. However, some OKC tend to present with atrophic epithelium and with early retipacts. These two pictures on the right hand side are still OKC if the clinical information given says that
is the past medical history. Let me give an example. In a patient with hyperparathyroidism, if there is a heart tissue lesion with presence of giant cells, we will call it a Brown's tumor because there is evidence of thyroid gland disturbance. The same also goes for a patient with history of radiotherapy and having red or white lesion inside the oral cavity. We must remember that the dry mouth found in these patients will predispose them to fungal infection. So if we are dealing with a white or red lesion in a patient with radiotherapy, history of radiotherapy, the pathologist will always go for a stain to rule out fungal infection. Other than past medical history, social history is also important. Quit chewing, smoking, and other habits like bruxism may contribute to some lesions inside the mouth. Here is one example. The picture shows a white lesion on the lower lip of a patient. Assume that the clinician was a bit worried and biopsied the lesion. Upon arrival at the lab, we happen to see that the tissue is very benign looking. There is no abnormal cells within the epithelium, just that the keratin layer has become thick, or in other words, there is a thickened keratin layer. So combining this histological feature with the clinical presentation, and we are told that the patient has a lip rubbing habit, we will be able to diagnose this case as epithelial hyperkeratosis secondary to lip rubbing. We will be able to issue out the diagnosis without any doubt. After the social history comes the clinical examination. The site of the lesion should be mentioned exactly, whether it is in the maxilla, mandible, or any parts of the tissue. The lesion also should be described correctly, whether it is appearing as a striae, patch, papule, plaque, or in small vesicles. Other than that, the color also is equally important, whether the lesion has white, red, mixed white and red. Apart from that, other information that need to be considered include size and consistency of the lesion, some associated features like ulcerated surface or finger-like projections. Finger-like projections may give us a clue that the lesion is having a papillomatous surface. Raised border and induration might lean or might point towards a malignant lesion. Other findings, if present and important for the diagnosis, it should be mentioned, like concurrent skin lesions, periodontal pockets, palpable lymph nodes, or non-responsive APT. Let's see a few examples. This first picture on the left side shows presence of small whitish yellow papules on the buccal mucosa. I'm sure we all know the diagnosis, even if we don't do a biopsy. Let's say the tissue has been biopsied, and under the microscope it looks like having normal looking sebaceous gland. So with the histological features combining with the location of the lesion, Clinically, we will happily call this as a fordyce granules. If the same normal-looking sebaceous gland appears clinically as a nodular growth at midline of tongue, now the diagnosis will become sebaceous choristoma. It is no more a fordyce granule. In this third picture, we are still dealing with sebaceous gland, but now clinically the lesion appears as yellowish papules which are larger in size and more in numbers. And histologically, still looking normal, benign, but only thing is the number of glands have increased. So, combining the clinical and histological features, the diagnosis now will move towards sebaceous hyperplasia. From these three pictures, what I would like to show is that when the location and the appearance of the lesion changes, the diagnosis also will differ, and the management somehow rather will also become different. Here are a few more examples. When the epithelium is normal with no pathology, we expect it to appear as a normal mucosa in the oral cavity. When the epithelium has a thickened keratin layer, it will appear most of the time as a white lesion intraorally. So this is known as hyperkarnatosis. The third picture here shows a thin epithelium. Due to the reduced thickness of the epithelium, the underlying connective tissue with its vasculature may become visible. Therefore, this lesion may appear red in the oral cavity, and the condition of the epithelium, we call it as an atrophic epithelium. The fourth picture shows loss of normal epithelial cells at one area of the tissue, and this represents an ulcer. So clinically, we expect to see a break in the mucosa and there is presence of ulceration, and this is an ulcerated epithelium. This is another example of a white lesion. The picture is showing a diffuse white patch on the tongue. Possibly it should be scrapable. So if we examine, we happen to biopsy and examine under the microscope, definitely we'll be seeing all the candidal hyphae. Let me show you how it looks like. The arrow here is pointing towards this, all the small, tiny features, tiny thing actually is candidal hyphae. Okay? This is another case of a white lesion, but this one differs slightly from the earlier one. Here in this picture, the lesion doesn't appear as a diffuse patch, but rather looks more like a white striae on both sides of the tongue. And there is also an adjacent area of an ulcer. Histologically, we are seeing candidal hyphae in the superficial epithelium plus some other histological features such as band-like lymphocytic infiltrate. In this case scenario, we can't call it as oral candidiasis, although there are fungal hyphae in the keratin layer. In this case, we tend to call it as an oral lichen planus with superimposed candidiasis because the clinical presentation is different, and also there are other specific features for oral lichen planus that are present histologically. The fifth subcomponent of the clinical information is the investigation part. If you have performed a blood test and the result is relevant to the case, it would be nice to attach in the request form. What I would like to emphasize the most in this part is the radiographic information. One of the reasons why we perform imaging is to identify the origin of the lesion, whether it's coming from the bone or soft tissue, because these two components have their own list of lesions. Other features like radiolucency, radioopacity, multilocularity, and so on will represent their own entity of lesions. For us who always deal with odontogenic lesions, it is very, very crucial to mention or describe exactly where the lesion is located. For example, surrounding the crown or an apical region. Because these two locations are very important to differentiate dentigerous cyst from a radicular cyst. For a dentigerous cyst, the lesion should show clinical evidence of the presence around an impacted tooth, whereas for us to give a radicular cyst, the lesion should be at the apical region of a non-vital tooth. So I would like to request to everyone that whenever a case of odontogenic lesion is being sent, please describe clearly in the request form. If possible, you can illustrate the lesion on how it looks like when viewed on the OPG. If you are worried that the illustration won't look nice, you can always attach a copy of the OPG for us to visualize. So I hope you understand why most of the time we go after the clinician asking for an OPG or other radiographic information. Over here, I have put up a request form where the clinician has nicely drew the lesion. So if we are supplied with this kind of clear information, it will help us with our diagnostic work. Now, let's go through a few cases. These are my own cases. I picked them thinking that the discussion part would show how the clinical and histological correlation are needed to arrive at a diagnosis. Okay, the first case belongs to a 20-year-old female with swelling at upper left quadrant for 5 months. There was an impacted tooth, and the upper occlusal radiograph showed radiolucency at tooth area. It was not mentioned whether the radiolucency was surrounding tooth, but I assumed it might be since the tooth is impacted. Upon examination under the microscope, the lesion showed non-keratinized epithelium with proliferation in arcading pattern in some areas, and there were lots of inflammation in the underlying connective tissue. If you don't take into consideration the clinical part, the histology alone shows classical radicular cyst. However, in the history, there is no mention of a non-vital tooth, only an impacted tooth has been mentioned. And we are not sure whether this lesion is surrounding the tutu, the crown of tutu. And at the same time, I was wondering why there was a lot of inflammation in the cyst if it is a dentigerous cyst. So I requested for the upper occlusal radiograph from the clinician, and this is how it looked like. You can see there is a radiolucency surrounding the crown and the cemento-enamel junction. And surprisingly, this impacted tooth had a caries at the cemento-enamel junction. So that explains why we are seeing lots of inflammation in the cystic tissue. So I even contacted the clinician and asked what was the intraoperative finding, whether it was really surrounding the crown or was it next to the adjacent tooth, the apical region of the adjacent tooth. The clinician told me it was really surrounding the crown of tutu. So for this case, since it is inflamed and then the lesion is surrounding an impacted tooth, I ended up signing it out as an inflamed dentigerous cyst. Our case number 2 belongs to a 45-year-old female complained of burning sensation on the tongue for the past few months. According to the clinician, there was a mixed red and white patch on the tongue. At this point of time, with the clinical history as such, I was imagining that the patient might be having oral lichen planus or non-homogeneous leukoplakia. I mean, that kind of lesions in the mouth. When I got hold of the tissue, it looked like this under the microscope. The epithelium was hyperplastic with elongated ridges. There were lots of microabscesses in the upper part of the epithelium. And this kind of appearance is known as psoriasiform pattern. It doesn't match for a lichen planus or homogeneous leukoplakia at all, but the history is giving some kind of clue that the lesion is red and white in color, and it was like going towards more of oral potentially malignant disease. So what I did was I asked for the clinical picture. Here you go. What do you think it is? Yes, the clinical picture shows a depapillated area surrounded by a white border. And the histological picture matches very well with the clinical findings of clinical features given by the clinician. So I signed it out as a geographic term. I think it is enough with our case discussion for today. We have come to the last slide. As a conclusion, the take-home message is that all histological diagnoses should be supported with adequate clinical features. We must remember that not all histological diagnoses can be made purely from the tissue's biopsy. Hence, we need some input from the clinical side. Some lesions also may present with non-specific features. Therefore, clinical correlation is always required for a correct diagnosis. With that, I thank you for your attention. I would be happy to take any questions from the participants.
Thank you, Dr. Savam. So I'd like to remind the participants, if you have any other questions, you can type in the chat box. And at the end of session, we will answer all your questions. All right. Okay, now we'll go for a 15-minute break. After this short break, please be here at 10:15 as we will proceed with the third the third ceramah. Okay, please be here on time.